Everybody, welcome to Commonsense Urology, where I go over common urological problems and offer a sensible approach to them. I'm Dr. Neil Gordon, and today's episode is on incontinence. Now, incontinence is usually defined as four types: total, urge, stress, and overflow. Total incontinence is the continuous leakage without any control whatsoever. Overflow is similar, but with one test you can differentiate the two. That test is an ultrasound. If the bladder is empty, then the patient has total incontinence. If the bladder is full, the patient has overflow incontinence. Really very easy. Now, overflow incontinence occurs because of obstruction to the outlet. Whether it's a large prostate in a man or a pregnancy in a woman, or any other type of obstruction, will be reasonably easily defined with the ultrasound, but if not, you may need to go to a CT or MRI to help define things further. Total incontinence is usually the result of a fistula, either through obstetric injury, surgery, diverticular disease, or any other such condition which creates a fistula. You'll be able to research those if you're really interested. Stress incontinence occurs when the pressure inside the bladder is greater than the pressure of the closure of the distal urethral sphincter. In other words, it occurs with a cough, laugh, sneeze, or straining. True stress incontinence is usually just a few drops of urine, then the person notices that, closes the sphincter voluntarily, and no more leakage occurs. This may be neurological or anatomical, such as contributed to by a prolapse. It's more common in women than it is in men. However, after certain types of urological surgery, such as radical prostatectomy, and maybe after a TURP, it may become the case in some men. Urinary urgency and urge incontinence is when the patient has to go, they have to go. Otherwise they leak before they get there. It may be a small amount, or it may be an even larger amount, and sometimes it's the whole bladder volume. This may be related to the rate of urine production. If a patient's on a diuretic, quite often they'll produce large amounts of urine quickly and may not be able to get to the toilet in time. Of course, mobility is important, and if the patient has had a stroke or is not nimble on their feet, they may not be able to get to the toilet in time either. Parkinson's disease is a problem also, but Parkinson's disease can also affect the distal urethral sphincter for stress incontinence as well. An ultrasound is a very important investigation in urge incontinence as well. If the patient has a small bladder volume, or their urge to micturate during the ultrasound procedure is below a level of approximately 400 to 500 mils, then the patient may have a small bladder capacity. If the bladder can't fill, then the patient will have urinary urgency. In addition to filling, if the patient has irritation such as inflammation or interstitial cystitis, or with certain bladder tumours, the urge to go is very, very strong. As with any patients presenting with any condition at all, it's very important to take an accurate history and also carry out an appropriate examination. In these patients, urinalysis is also very important. Now, first of all, the history. What you need to really assess is the type of fluid and the amount of fluid. Caffeine-containing drinks make the patient make more urine more quickly and can cause irritability of the bladder. Alcohol, of course, makes urine more quickly in most patients in large amounts. Timing of the patient's fluid is important. A lot of patients complain of nocturia, but they'll have a few drinks before they go to bed, and some of them, when they get up to the toilet, will have another glass full of water. I remember seeing a patient, old lady, 80 years old, approximately 50 kilos, who assured me that she drank her 8 glasses of water a day. The 8 glasses of water amounted to approximately 3 litres. It's not surprising that she couldn't go further from a toilet for an hour or so. Quite clearly, she was drinking too much. Approximately 1200 to 1500 mils would have been sufficient for her. On the other hand, I've had a male patient sent to me for nocturia, who drinks 4 litres during the day as an electrician when he's working in a roof. Fine, because he sweats a lot of that off. But when he gets home, he drinks a 6-pack of beer. It's got to go somewhere. So do take a proper history and an appropriate one for the right patient at the right time. Both male and female patients, abdominal examination is important. It's also good to check for hernias because sometimes the bladder wall can be trapped in an inguinal hernia. It's a good idea to do a speculum examination on a female patient because uterine, cervical and anterior wall prolapse is very common as ladies get older, and this can lead to opening of the urethral sphincter and less competence as a result. As previously mentioned, an ultrasound of the urinary tract is important, particularly regarding bladder emptying and the degree of fullness that the patient has felt compared with the amount of fluid in the bladder. Having the patient complete a fluid volume chart is extremely important also. They should write down the time of day, the amount and type of fluid consumed, and the amount and time of day that they empty their bladders should be measured also. It's important for them to say whether they had to hurry to the toilet in time and whether there was any leakage prior to getting there. The fluid chart can be completed during the few days it takes to arrange and have the ultrasound done and to get the report back. Usually a week is sufficient to know what's going on. Don't forget, you still need to do a urinalysis when the patient comes to see you because you do want to know if there's any sign of hematuria or infection in the specimen. Now, if the patient really has to go to the toilet when having the ultrasound carried out and there are 250 mils in the bladder and the patient starts to leak in the ultrasound room, then that may indicate a small contracted bladder. The best way to assess that is with a cystoscopy under general anaesthetic, when the bladder can be inflated to its maximum capacity without any sensory input affecting the patient and without causing pain. If the patient's bladder is seen to hold around 600 mils under that examination, then clearly the bladder is not contracted, and quite often that procedure alone will assist with improving symptoms. Also, however, if the bladder capacity really is very small, then there's no amount of medications, exercises, or changes to their fluid regimen is ever going to make them any better. Those patients may well need to have a bladder augmentation procedure, which is a major procedure where segments of bowel are substituted over the bladder as a patch to enlarge the bladder's capacity. This is very serious surgery. It's done on both the bladder and the bowel. It's not everyday stuff, and it should only be contemplated under extreme circumstances. Now, sometimes a urinary diversion is appropriate. For example, in a patient who's had pelvic surgery for either bladder cancer or in the male's case in prostate cancer and radiation, where they've contracted the bladder and the bladder is a fibrous, hard shell and cannot expel the urine. Urodynamics is a study which is designed to demonstrate bladder function by measuring the pressure in the bladder, its ability to hold water, and its ability to contract and pass it out. Adult humans make urine from approximately 30 mils an hour to 100 mils an hour. Obviously, if fluid was run into a bladder at 100 mils an hour, in order to get a normal capacity of 400 or 500 mils, the procedure would take 4 or 5 hours. Now, urodynamics clearly doesn't take 4 or 5 hours to carry out, and therefore the water has to be run in at a faster speed. Everybody knows what happens when you do a patella knee jerk test. You tap the patella tendon and the lower leg extends. Similarly, if you fill a bladder rapidly, then it will tend to contract. Also, urine is made at 37 degrees. If you run water in at a lower temperature than that, just like any muscle, it will twitch and shiver. In the bladder, this can often be referred to as bladder instability, but that is not correct. It is a response to cold. The long green catheter goes into the bladder. It contains a filling lumen and a pressure transducer, and the small green balloon is seen on a white background. That's the one that goes into the rectum. The fluid is run in and measured as a reduction in the weight hanging from the container. These show the pressure transducers and the warming unit. The patient passes urine into this little toilet with the catheters still in place to measure the pressure of the bladder and the flow rate at the same time. And this shows the tracing which is obtained. So when should urodynamics be done? In my opinion, almost never. And that's also the opinion of various urological organisations around the world, including the AUA, EUA and NICE, as shown in this table published in the British Journal of Urology. It's an unpleasant test. It gives you no further information than you can get from history and examination and common sense management. For example, if a patient does have a small bladder, apparently on voided volumes, then a cystoscopy under general anaesthetic will help assess the actual bladder capacity. If it is small, then management accordingly. If it is not small, then the patient may well have sensory urgency and then require following this treatment plan. It's very important to treat the cause, and in some patients it will be related to UTIs and they will require management of those. Also, some women require hormone replacement, often in the form of topical estrogens. Medications such as anticholinergics, antimuscarinics are useful. Beta-adrenergic agonists may also be helpful, or intravesical Botox injection. However, it's always still necessary to carry out a urinary chart for information on progress. So stress incontinence is really a problem with the washer in the tap. It just needs to be tightened up a bit. And one of the best ways to do that is with exercise and weight loss, also with pelvic floor exercises and physiotherapy. Topical estrogens can be helpful. If a small amount of estrogen cream is placed around the urethra each night, it seems to work very, very well, rather than putting it inside the vagina where it melts and runs out. A lot of women don't find that very acceptable. Then, of course, if the patient does have anterior wall descent, an anterior repair, plus or minus a hysterectomy if there's a prolapse. Bulking agents such as Bulkamid are very effective, and it's a quick, simple 10-minute procedure to be done with a cystoscope, with no stitches, no wounds, and is very comfortable and works instantly. Some patients do require top-ups of the bulking agents from time to time. In addition, there are various slings and tapes which can kink the urethra when the patient coughs or sneezes, because they are attached to the abdominal muscles which tighten up the sling. A colpo suspension is a lifting up of the anterior vaginal wall to support the urethra, and an artificial sphincter can be inserted when all else fails, but is usually more the case for total incontinence. As a general rule, it's best to treat the urge incontinence first and the stress incontinence second. The patient's mobility is the problem, and therefore timed toileting, with the patient going to the toilet every 2 or 3 hours, is the best form of management. No, this is an artificial urinary sphincter. This cuff is placed around the urethra. There's a reservoir of fluid which is under the abdominal skin, and this is the activator which moves the fluid from the balloon to the cuff to create continence. It's then released when the patient wishes to pass urine, in order to let the urine flow. The activator is placed in the scrotum of the male and in the large labium of the female. It depends whether they're right-handed or left-handed as to which side it's placed. Finally, here is a summary of the modes of management of urge and stress incontinence. Thank you for watching this episode on incontinence. I hope you've enjoyed what you've heard and seen, and if you have, please consider giving a thumbs up. Also, consider subscribing by clicking on the little logo at the bottom right-hand corner of your screen. Don't forget to click on the notification bell to hear of many more episodes to come. Cheerio!